Greetings. The title of this lecture is Intraradicular Preparation and Management per Dental Practicality Index, which is based on the recent literature and some explanatory images from my practice or Google search. To simplify this lecture, the outline is divided into definition and rationale, preoperative assessment per dental practicality index, endodontic treatment need for dental practicality index weighing 2, biomechanical principle, techniques, and finally some clinical cases. So the definition of intraradicular space is the outcome after we remove the pulp tissue from inside the root. And it's usually occupied by the obturation material, which is mainly core material like gutta percha and the root canal sealer. The preoperative assessment, it usually includes removal of caries, removal of any weak or undermined enamel or dentin, exploration of any cracks or fractures, and then generally assess the remaining tooth structure. So doing the preoperative assessment without having like a scale or a reference will make the decision of how to use the existing remaining structure a little bit confusing. That's why the Dental Practicality Index is useful in this situation. It will provide a framework for assessing the teeth, and then you could plan the treatment option. And then the restorative state is assessed along the local and general context of the teeth and the dentition, and then you and the patient could make a decision that is suitable for the patient need to have to retain this tooth or to extract it. So the Dental Practicality Index is a result of evaluating the structural integrity, the periodontal treatment need, the endodontic treatment need, and the local and the general context. So it is a very collective of all the significant factors that affect the decision of what to do to restore this tooth. And this slide divided the way based on the actual execution in the clinic. So weighing 0, it means that there is good tooth structural integrity is sound. There is almost no periodontal treatment need. The endodontic treatment may be none, the tooth is vital. Or you have a successful previous root canal treatment. The most level we see or way we see in the clinic is the weighing number 2, which means that there is a significant loss of the tooth structure coronally, which result in minimal remaining tissue. There is effect on the periodontium, and the root canal system is usually complex, or there are some errors within the root canal treatment that requires retreatment, which is the most of what we face clinically, and we use the Dental Practicality Index to make the decision, is it worth it to do all these steps, like post-anchor, endo retreatment, crown lengthening, or maybe it is needs some time to assess the cost and the time and then the prognosis, and maybe we could choose extraction and implant. And this is always left to the patient to decide based on the input or the options that you provide to the patient. For simplification, the Dental Practicality Index is a numeric scale, as I mentioned earlier, based on accumulative and recognized criteria. And it recognizes the upper limit that can be included in the way itself. So anything usually from 4 to 6, usually those teeth, if the outcome is 4 or 6 dental weighing in the Dental Practicality Index, the tooth usually go for extraction. So, as I mentioned earlier, this is level 0, where the bulb is vital, or we could have successful RCT. And in level 1, we have a successful RCT without significant loss of the coronal tooth structure. Those are straightforward cases, doesn't require more elaboration from my end. That's why we will go to level 2, which has a lot of endodontic treatment need. And the outcome usually, as in this image, you're gonna leave some gutta percha apically and some of the canals without post. Then the tooth will receive post and core buildup. Now, how we actually apply the dental practicality index into our clinical practice. First thing you have to do, you need to remove all existing restoration, any caries. So you need to do the preoperative assessment. We have this example. If you look at the image with the tooth colored filling, it doesn't look as it is really after you remove the restoration. You can see there is caries, and then the caries was removed. When we remove the caries, you can see that there is a missing canal, which is treated, and then the tooth received in-term restoration. After finishing the endodontic treatment and excluding the presence of fracture or perforation, then we can give the case to the prosto, and they can make the correct decision on how to restore this tooth. And the prosthodontist usually have those guidelines in sight, and they usually apply it. They usually leave 4 to 5 millimeter of gutta percha apically after post-space preparation, and then usually the post-space preparation does not go beyond the curvature, and they use usually flowable material to cement the post within the canal. They usually keep the post within the core, and they usually restore the crown with a temporary crown, and then it receives the final crown. Now we go to the biomechanical principle of intraradicular preparation by itself. We have two aspects that we need to keep in mind. The biological aspect include respecting the long axis of the root. That means you don't undermine one of the walls, you don't perforate. We aim to leave an equal thickness of dentine surrounding the canal or the post space, which will enhance the force and stress distribution along the root. And as I mentioned earlier, the apical third is usually left with the root canal filling, and it's a practice that's been there, and it's mainly for feasibility. It's very rare that someone actually take the post and take it to the apex. This is the biological aspect. When we go to the mechanical aspect, which mean we need the retention, it's important to keep in mind the crown length. You cannot have a post that is above the bone level, and also the occlusion is important. Now we're gonna see what is the recent update in the scientific literature about intraradicular preparation practice. When you go through the literature, it's important to know what kind of evidence that you are looking at. The more systematic and organized and accumulative result, the more it is applicable in a general term. That's why systematic review and meta-analysis have the highest ranking in citation of literature. Then randomized clinical trial, then cohort study, then case control study, then the reports, and then some opinions. The randomized control trial has the control group in addition to the test group. And then the systematic review and meta-analysis will collect many randomized clinical trials. The cohort study, usually you cannot control the setup, but this is what is feasible for this problem to study it. So it is used and then we accumulate it. We will start with which irrigation technique is recommended for intraradicular space preparation. Continuous irrigation was found to result in the highest bond strength in the apical third. Then, which obturation technique is recommended for intraradicular space preparation? At the moment, there is no significant difference between the available technique in the clinics. Most practitioners prefer more vertical, but the evidence now is moving toward no difference between the technique. Then the time of doing the intraradicular space preparation. The evidence today, 2021, is more favorable toward immediate post-preparation because it is more beneficial. It prevents apical leakage according to this study. Then, which endodontic procedure promote adhesion to intraradicular dentine? We're gonna go through this paper, which is really summarize some of the advisable clinical practice that you might apply to your clinic to improve the outcome of intraradicular adhesion. Sodium hypochlorite is used during root canal cleaning and shaping, and the negative effect on resin polymerization can be minimized by removing the smear layer using the Edita, and then if you could wash the canal with saline and then use chlorhexidine, this will inhibit the self-degradation of collagen fibers. Also, if you consider using non-eugenol based root canal sealer, this will prevent any future interference with the post-space cement, which is usually resin based. Also, there are two practices that you need to keep in mind when you are preparing the root canal space. It's advisable, as I mentioned earlier, to do immediate post-space. That means you're gonna remove the gutta percha and the sealer in the same visit, so the walls of the root canal will be clear and ready for post cement. And if this was not done, it's advisable to remove the gutta percha using a heated instrument, like a heated plugger, and then and this will prevent the incorporation of the gutta percha within the smear layer. So when you file the walls or wash them with irrigation, you will have a better chance of opening all the surface for the new hybrid layer during post cementation. Also, it's advisable to consider using a dual or chemically polymerized cement because the light source is far from the apical third of the root canal space. So in conclusion, there are three aspects that you need to keep in mind to have more efficient adhesion of the post to the root dentine, which are the surface treatment during endodontic procedure, then the selection of the adhesive resin, and then the polymerization of the cement. In the same article, they have a useful table about the recommended protocol for cementing post to root dentine. And the first thing is actually to maintain good isolation because you are using a resin-based cement. And also, they have recommended the use of diamond bear, which produce a smear layer that is easier to dissolve compared to carbide drill. Now, the timing after you create the intraradicular space to receive the new prosthetic treatment is to make it as soon as possible, because the objective of all of this is to give the patient a functional unit that will last as long as possible. The other important aspect during creating the post space preparation is the bone level. It is very important to make the post space below the bone level to ensure that you have a better forces distribution of forces along the root, and it will prevent fracture. We finished the theoretical part. Now we will go to the how to do it. So you need to have a prosthetic treatment plan based on what I mentioned earlier. Then the apical third of the root canal has to be filled with gutta percha and the sealer. Then the heated plugger is used to remove the extension of the accessory cones. And then you're gonna apply a few drops of chloroform to dissolve any remaining sealer. This is how you create the immediate intraradicular space. And this is a clinical case where this is the preoperative radiograph, and then in the post-operative radiograph you can see that there is a post space, and then after 1 year it's fine. It has no negative effect on the periapical health. The advantages of immediate post-space preparation, that the operator is still familiar with the root canal morphology. So when he drive the bear inside the canal, he's still oriented. So the chances of iatrogenic error is less, and it is also done by the same operator. You will have some vertical compaction of the apical filling, and there is also less shear time because you did not fill the whole root canal, and then it doesn't receive another visit to remove the 7 or 11 millimeter of root canal filling in the root to create the post space. Now we will go to the delayed intraradicular preparation, which is the most common because who usually do the endo is separate from the one that do the prosto part, and usually there is no fixed prosthetic treatment plan that make the endodontist prepare the post space after doing the root canal treatment, either because they are in different practice or because the patient did not yet choose a prosthodontist to restore this tooth. So the main guidelines for intraradicular preparation is to use non-end cutting rotary instrument, to do as minimal as possible of canal enlargement after the root canal cleaning and shaping. You have to have at least 1/3 of the root width. The length is at least equivalent to the crown, and you have at least 4 millimeter of gutta percha apically. And the post is modified. That means you do for it some trimming, or you make it customized to fit the canal. And it should not apply any wedging forces inside the root, and it should have an adequate frill. All of this is to prevent fracture. Now, how to remove the gutta percha? Usually the gutta percha, as I said, it's preferably to remove it with a heated instrument. If not, you could use one of the latch type bears, either the post preparation bears or the Gates-Glidden. Also, you could use the files, either hand file or a motor-driven file to remove any gutta percha, and then you need to pack it apically, and the walls are cleaned chemically. If the gutta percha is being in the canal for a long time, sometimes you need to dissolve it a little bit chemically before you drive a motor-driven instrument to remove it. But we mentioned again and again, gutta percha is better removed by heated instrument to prevent its incorporation within the smear layer. So what are the disadvantages of the several techniques? As you all most probably know by now, that if you drive a motor-driven instrument within the canal and you are not familiar with the long axis, usually you will have perforation. If you leave the heated blugger inside the canal for a long time, you will damage the periodontal tissue. And if you don't have a rubber stopper, when you are using any instrument inside the canal, you might remove more gutta-percha, which will cause a little bit of more time and another procedure to refill this part. And it's very important to know that the post will help reinforce the remaining coronal tooth structure, but post space preparation can significantly weaken the root. The next paper showed that the presence of frill will increase the fracture resistance of the restored tooth regardless of the post that is used, because most of the stress concentration is in the cervical region. Now we will go to some clinical cases as we apply the dental practicality index during the execution itself. So the dental practicality index for this tooth was 4 because it is tilted and it lost a significant coronal structure, and there is a significant loss of bone in the around the root. But the endodontic treatment need level was 1, and the patient chose to keep the tooth. Thus, the endodontic treatment was executed, following by the prosthetic part, and then it showed good signs of healing, and the patient is satisfied with it. The next case also, it has a dental practicality index weighing 4, and the endodontic treatment level is 2 because we have to remove the casted post and core. The next question is how to remove those casted post and core. The answer is usually vibration, which I will talk about it in the next slide. What is important in removal of casted post and core is that you need to free it. At the coronal level, you need to completely free it. And then when you apply the vibration will just break the cement between the post and the root wall. You don't want to vibrate at the crown level because you don't know what kind of fulcrum will be created and it might cause fracture. So the vibration, as it's shown in this image, you're gonna do it circumferentially, clockwise, anti-clockwise, and you can also apply it vertically from the coronal to the apex, to the apical direction, because the idea is to break this cement. And there are some units that was sold in the market to remove the post. I don't use it personally, but it's available if you can fit it in the mouth of the patient. So the conclusion is intraradicular space preparation is critical in endodontic treatment need. So first, confirm that the tooth has a dental practicality index less than 6. Then consider bone level, root anatomy, accessibility in intraradicular space preparation. If you have any question or concern, kindly reach me via email. Thank you and have a nice day.